Thank you. So those are the introductions. Thank you for everybody for taking the time to listen to everybody's name. We think it's important to just kind of know who our community is here. And so any questions as we come up, feel free to put them in the chat box. Other than that, we'll just hand it off to our able presenter.
All right. Thank you very much. Thank you, everybody, for attending today and also introducing yourselves. It's nice to hear about the variety of backgrounds of the individuals in attendance because it helps me as a presenter. Also, I would ask that definitely type in questions. I tend to appreciate more of a dialogue rather than just a direct, this PowerPoint presentation. So please, along the way, stop me if there's anything that I can clarify or if something comes up. So as we mentioned, the topic today is delirium, a geriatric syndrome. And I chose to present on this topic because as a geriatrician, this is actually partially what got me interested in geriatrics to begin with. I find delirium to be one of the more interesting geriatric syndromes because it leads to basically working up delirium can be one of the most rewarding investigations. And one of the most important things to mention about delirium is that ultimately it is a reversible syndrome. So we'll talk more about that. And I want to give you some additional brief information in this introduction. First of all, delirium is an extremely common geriatric syndrome. We admit multiple veterans a day through our emergency department in this state. And it's a very distressing syndrome, I might add, not just to the patient, but also to the family members and caregivers who participate in the care of these individuals. These frail and vulnerable geriatric patients living in the community with a change in mental status is certainly a very concerning scenario. And so I just want to underline the seriousness because it increases both the morbidity and the mortality of this population. And so it needs to be recognized early. And the later that it takes to identify sometimes what can be subtle changes in an individual's cognition, the syndrome can actually potentiate and become worse over time. I think it is important to note that, and part of my objective in this presentation is to help you better understand the complexities of this geriatric syndrome and the fact that it overlaps with other geriatric syndromes. For example, a hypoactive delirium can be masquerading as a depression or vice versa. And so that being said, delirium shouldn't be confused with dementia, although patients with an existing diagnosis of dementia or mild cognitive impairment are more likely to develop a delirium. And it's the third presentation of this series, which will be presented next month by Dr. Lavi, is going to go into more depth on dementia. But essentially, some of the major differences between delirium and dementia is, and what I can tell you is probably the most important distinction between the two, or at least way of determining, is the acute onset of delirium. So when we look at dementia, we're talking about a chronic, progressive, and generally irreversible change in cognition. There are obviously several variants of dementia, but even in the spectrum of a dementia in an individual patient, there can be acute and sudden changes in the sensorium. So delirium can have a variable course, as I mentioned earlier, and what I think is probably most important is that it is usually reversible and preventable to some degree. I have to say that in terms of medical interventions and medications, it hasn't been shown to be preventable prophylactically through administration of drugs. However, there are things that one can take into account when caring for a geriatric patient and hopefully prevent an episode of delirium. So, basic definition, this is from the DSM-4, which has been published within the last 5 years. Although I do have to say, DSM-5, there was no change across the definition from the DSM-4 to the DSM-5. And you can see that, as I mentioned earlier, probably the most important element of the definition is the acuity of onset and or fluctuating course. So, and when I say acuity of onset, by the way, I mean to say that it develops over a course of hours to days. So a subsyndromal delirium may manifest but go unnoticed for a period of time, but only to emerge more floridly after several days. And only kind of then in hindsight might a caregiver or a loved one say, oh, actually, you know, there was something really funny that, you know, that Dad did the other day, and I sort of wrote it off. So in any event, the acuity, and then next of importance is the inattention. And so inattention kind of can be variably defined as inattention to one's environment or situation. So, for example, a patient may not be able to attend to an understanding of exactly where they are, and that might persist even past providing cues. Inattention can also manifest more subtly when upon cognitive testing, and the inability to focus or recall information that would otherwise readily one would readily be fluent in would help define the inattention. The next element is the disorganized thinking or the altered level of consciousness. So altered level of consciousness really is looking at an individual sort of on the scale of wakedness versus somnolence and variables in between. And then the disorganized thinking. So disorganized thinking being an inability to organize one's thoughts, answer a question directly, maybe speaking or talking sort of in circles. And this, you can also see, it maybe as a sub-element to this portion of the definition, that individuals with delirium can frequently develop hallucinations, either visual or auditory, which can of course be extremely disturbing and help, but nevertheless help move towards that diagnosis. So I'm going to discuss a case that of a gentleman I recently cared for over the last, I think, 6 to 8 months, just to give you kind of an example of a case of delirium and sort of the outcome being what I found most profound here. So a 92-year-old gentleman was admitted through our emergency department at the VA, and he was found to have altered mental status, confusion, and was described as psychotic by the physicians who evaluated him in the ER, and did display behavioral instability and was somewhat combative with staff. And the only thing he was able to really sort of verbalize was that he was being chased by giant rocks, which certainly sounds like a psychotic statement on its face. And he added to that he could hear nothing but loud marching music coming at him in all directions. And so, interestingly, this gentleman presented with a past medical history significant for hearing loss, which had previously been corrected using hearing aids, and visual impairment. I believe he had cataracts. Well, anyways, suffice to say he was visually impaired as well. And so that dual sensory impairment became even more significant over the course of a week or so, when he lost both his hearing aids and his glasses. So the reality of his perception was that, yes, everything did appear like a giant rock, and he couldn't hear anything because his hearing had previously been corrected, or at least improved upon, with the hearing aids. Two other significant elements to his past medical history, which I want to bring to your attention, are the BPH with the chronic indwelling foley, also a risk factor for delirium.
What's BPH?
BPH is benign prostatic hypertrophy, and he had the indwelling foley catheter because he additionally had long-standing neurogenic bladder. And so, with that being a risk factor for dementia, for delirium, we'll get into that a little bit more later. Also, I want to bring to your attention the arthritis, because painful arthritis on its own can also, or any source of pain for that matter, can predispose an elder to delirium, especially when you're looking at some of the other variants of arthritis outside of your garden variety osteoarthritis. So you have gouty arthritis, for example, where a joint may, over the course of a very short amount of time, become bright red, inflamed, and extremely painful. And being in that scenario of uncontrolled pain is a huge risk factor for delirium. So this gentleman, on his hospital course, basically had normal labs. Not surprisingly, and I'll touch on this later, the CT scan of his brain was normal. Imaging does not tend to be helpful in defining an etiology for delirium, other than a couple of specialized scenarios. He had mental health assessments, but these were early on his hospitalization, and he had been known to have mild cognitive impairment prior to the admission. But at this point, with him being delirious, he was without capacity to make decisions. And so I know capacity is going to come up in a later Project Echo presentation, but let's suffice to say that individuals who have been diagnosed with a delirium do not have capacity. So this gentleman was medically stabilized and transferred to our skilled nursing facility, and at the time that he had been admitted, case management had kind of bandied about this idea that, oh, he's probably going to need a guardian. Well, so that turned out to be a little premature. We were able to connect him with our audiology department, replace his hearing aids, get him over to our eye clinic, get him a new pair of glasses, and by the time those things were replaced and he had some time to get used to his environment, a repeat cognitive assessment revealed that he did have capacity for decision making. And so he ended up participating in a plan that resulted in his discharge and subsequent vacation. So it's kind of a nice ending to this case. And typically, to be clear, when our psychology colleagues evaluate patients such as this individual, they do take active measures to provide hearing devices like a pocket talker or something, but it doesn't replace, the hearing aids and the prescription lenses that this veteran needed to thrive in the community, given that he did live alone. So there's varying presentations for delirium. This gentleman experienced what is typical of a lot of geriatric patients. It's this cascade of events resulting in his confusion, subsequent hallucinations, and aggressive behaviors. Cognitive assessments were performed, as we mentioned. It wasn't until he transferred to SNP that we were able to remedy some of these problems. You know, I think part of the take home on the case too is that the thought that, you know, delirium can sometimes be mistaken as symptoms of a psychiatric disorder, which this gentleman does not and did not have a psychiatric disorder other than the fact that he presented in a state of acute delirium. So it's a complex presentation, but in my estimation, an interesting case for the dual sensory impairment and what that led to for this individual. So incidence of delirium increases with age, number of comorbidities, and severity of acute illness. Taking care of and being familiar with patients in the VA, all of our patients have multiple comorbidities. And the severity of an acute illness can be impacted by a lot of factors, including access to care and ability to identify illnesses early. A third of elderly patients admitted to the hospital experience symptoms of delirium. And I realize that my citations below are not that timely in terms of 2006 and 94, but this is really still a true prediction and estimate today. So delirium occurred in 15 to 53% of geriatric patients postoperatively and 50 to 80% of ICU patients. So the take home there is just that, you know, my eye goes right to both of those 50%. So if you're looking at a geriatric patient, especially one who might exhibit signs of frailty or pre-existing mild cognitive impairment, you can pretty much flip a coin to decide whether or not they're going to experience delirium once they're hospitalized. And that can be from an elective hospitalization and even more likely in a hospitalization for acute illness or an exacerbation of a chronic condition like COPD or CHF. So additional settings, and of course the setting that I'm most familiar with being long-term care and assisted living facilities, we see this every day. And our nurses, of course, we're very lucky to have such skilled nurses who are the first and front line to being able to let us know that, you know, Mr. S is not acting like himself today. These are the things that I noted when I offered him his medications this morning. And so just the long-term care setting, you know, is a place where we frequently detect these subtle changes, and if we're lucky, we're able to perform an assessment and make an early diagnosis. So as I mentioned earlier, delirium in all settings carries an increased risk of mortality, and so, you know, we really need to be mindful about these underlying conditions that are inducing these delirious states so that we can try to avoid. The prognosis after diagnosis is, I think, very eye-opening. 10 times increase in hospital mortality. I mean, that is huge. And 3 to 5 times increase of acquired complications. And so an acquired complication from an episode of delirium can be a fall. That comes to mind most urgently because falls frequently result in death or complications that then can result in death. So again, being mindful of the cascade and what we can do up front to identify these patients early. And if at all possible, at least delay the progression towards nursing home placement or institutionalization. The nursing home is a fact of life for elder Americans. And the reality is we can't 100% avoid placement, but there are sometimes things we can do to help at least delay that. And so I would add being mindful of cognitive syndromes and delirium.
So we do have a question here.
Sure, yes, thank you.
The DSM-5 definition for delirium does not appear to specify if the underlying etiology is medical versus psychiatric, correct?
Correct.
It implies to be medical as it defines to be an acute onset, of an acute onset. Is there a distinction between delirium and hospital-associated psychosis?
They are the same thing.
Okay.
And I meant to mention that earlier. So delirium goes by lots and lots of different names. So thank you for pointing that out. Hospital-associated psychosis, sundowning, encephalopathy, acute confusional state, change in mentation. There's so many ways of saying this, and whenever I go back and I'm reading H&Ps, especially for patients who I'm admitting to long-term care or to acute rehab, I'm able to dissect out some of that language and figure it out. But in the moment when you're assessing a patient in an urgent or emergent situation, you have what you have in front of you to evaluate. Certainly, individuals with comorbid psychiatric illnesses, including but not limited to schizophrenia and other other variants of psychosis, like depression with psychosis or bipolar with psychosis. These should be differentiated from delirium, but ultimately are towards the end of your differential. So you're going to rule out all of the medical causes first before assuming that the delirium is a purely psychiatric etiology. Does that help?
And the one thing I would add to what Dr. McCaleb was saying is that sometimes we know people that have liver failure can get a hepatic encephalopathy. That's delirium.
Right.
People that are in renal failure and getting confused, that's delirium.
Right.
People that are having acute heart failure and they're not getting enough blood to their brain, that's delirium. People with COPD that aren't getting enough oxygen, they're getting confused when their oxygen levels are low. That's also delirium. And so this is a common thing we see all the time. We're just doing our best to expand the definition and let us all know what delirium really is.
Absolutely. And to go back to the terminology of hospital-associated, that is a function of the change in environment for the elder patient. So if you have somebody who lives at home and their environment is essentially their 2-bedroom home, their armchair, their comfortable bed, all of the things that they have in their home, that change in environment to this very sterile room with curtains and lights shining above their head and noises and things like that, just that change in environment is part of that hospital-associated psychosis. And when it occurs at nighttime, that's where you'll hear that terminology of, quote, sundowning. Again, I want to say thank you for pointing that out.
Okay. And another question here, is the geriatric population predisposed to delirium if they are also diagnosed with Parkinson's disease with mild to moderate cognitive impairment?
Yes, absolutely. They're predisposed not both for the Parkinson's disease independently, as well as the cognitive impairment, which may or may not be related directly to the Parkinson's decline. So, yes.
Okay.
So, cost of delirium, essentially with people living longer and life expectancy growing, the financial pressures on our healthcare system are great. And when we're looking at resources and the limited nature of those resources, we have to look at delirium given the fact of the state of, or at least prevent through the lens of prevention in hospitalized patients. Because the figure that I came across was that it can add a cost of $16,000 to $64,000 per patient year versus somebody who's hospitalized without delirium. So certainly, I think the brunt of that cost is coming through in additional days of hospitalization, because the acuity portion, or potentially at least what could be determined as an underlying etiology is the first, order of business in terms of diagnostics, but the symptom itself can linger for up to 6 months after a hospitalization. So, and the percentages that I looked at today were approximately 20% of patients with delirium still have some of the confusional state present a month after diagnosis, and up to 20% 6 months out. So, we're looking at something that can be protracted. And like I said, at the early phase of that, or the detection state being, the hospital, those days add up. So the assessment, the standard assessment, and approach that I teach my fellows and residents to perform on patients where delirium is being worked up is the CAM assessment. I actually just include it in my geriatric H&P, even when cognition isn't necessarily an issue for what I'm working a patient up for. I will document the absence of a delirium in patients who have risk factors. But incidentally, it's not different from your DSM-5. So the major criteria, it just separates this out in major and minor. Acute change in mental status fluctuation, we talked about the disorganized thinking, altered level of consciousness. So you can utilize various cognitive assessment tools, but you're not going to get very far theoretically when somebody is delirious. And the other part that I wanted to mention here was just the variance on delirium. So when I come in and I'm looking at a patient with a change in cognition from a geriatric perspective, and I diagnose a delirium utilizing the CAM method, I differentiate whether I'm seeing a hypoactive delirium, a hyperactive delirium, a mixed delirium, or what I'll briefly mention in another slide, terminal delirium. So hypoactive delirium is defined by psychomotor retardation, slowing, and hyperactive being, I think, what we see more commonly, and then tend to use the term agitation. And this is where we see a lot of behavioral symptoms that can be very difficult to control in any setting. And then the mixed is alternating signs, and like we had mentioned earlier, part of the diagnostic criteria is the fluctuating nature of the cognitive status. So terminal delirium can emerge in the last hours to days of life. I've actually seen it last for weeks. A terminal condition, or at least a terminal diagnosis, is not a reason to not work up delirium. I, as a hospice practitioner and palliative consultant, I have come across individuals in the hospital who are presumed to be dying and are actually delirious, and just doing something as simple as, abdominal flat plate reveals constipation, which is relieved, and then the individual is, granted, still has a terminal diagnosis, but they're now cognizant, and they now have that ability to interact with their families during the last hours to days of their life. And so it's important to work up delirium in terminal patients. However, it's not always reversible in these instances, and some of these behavioral symptoms can be very disturbing, probably more so for the family. But that is the one exception to the reversible nature of a delirium. So risk factors, as I've mentioned before, looking for signs that somebody is going to potentially develop a delirium during their hospitalization. You have your intrinsic or fixed factors, which can include age. Risk goes up with age. As age goes up, risk for delirium goes up. Pre-existing cognitive impairment, whether that's mild cognitive impairment or severe neurocognitive dysfunction. Chronic illnesses and the sensory impairments, as I had noted in the case example. The extrinsic risk factors being modifiable in presence of infections, pharmacologic, which I know was the topic of the last presentation, and polypharmacy certainly is a modifiable risk factor. Neurologic or neurologic conditions, like the participant asking about Parkinson's disease. Cardiac risk factors, renal and urologic is probably one of the biggest extrinsic risk factors. We had talked a little bit about benign prostatic hypertrophy and or urinary retention and the need for a device such as a Foley catheter to evacuate urine. Huge risk factor because a lot of individuals with renal and urologic conditions require catheters for long periods of time. And of course, we have endocrine and metabolic causes as well, diabetes being one that I should mention.
Question here.
Yes.
Are caregivers and family members included in the assessment methods?
Yes, absolutely, because almost uniformly, the acuity of the onset started before they arrived at the emergency department. So we have to be mindful of getting collateral information from caregivers and family members of these patients 100% of the time. So family members are crucial to informing the onset and getting all of the information because they know these loved ones better than anybody else. So absolutely. I was going to mention something else about that. It'll come to me later. So other risk factors. So we had talked about, so infection, most common being UTI. So I'd like to mention at least that, if anybody knows what the most common presentation is for a UTI in an elderly patient, and I'll give you the answer. Delirium. So the change in cognition is the #1 presentation for an elder with a urinary tract infection. So pneumonia or previous history of pneumonia, and then polypharmacy, so some drugs just off the top that are more likely to cause delirium being antipsychotics, benzodiazepines, antidepressants, opioids for sure, sedatives, and all of the anticholinergic urinary incontinence medications. Risk factors can include cardiac conditions, neurologic conditions, and renal failure and urinary, which I already touched on. In terms of the neurologic, I mentioned earlier that imaging is typically not, or at least imaging of the head in the form of CT scans and MRIs is typically not very helpful. The exception to that would be an individual who suffered trauma, because an intracranial hemorrhage can certainly be most readily diagnosed with a CT scan. And or the second scenario is somebody with other neurologic changes on physical exam, which we'll get to.
Did we have a question at William B. Ryrie Hospital? Ely, did you have a question?
No, we're fine. We're good. No.
Okay, thanks. All right.
So hydration is a very important factor for and dehydration. The lack of drinking enough water is a huge risk factor. That's actually the most recent case that I've reviewed in the last 24 hours was, and this is why nursing home patients are typically, while we don't do strict ins and outs, nurses continually assess access to fluids of patients and do encourage hydration. I mentioned earlier constipation, which is also a factor of dehydration, diabetes, and hyperglycemia. And then we had already talked about psychiatric disorders and covered that being part of the risk factor as well. So in terms of prevention, identifying the modifiable risk factors, but the number one strategy I have to mention so that it can be understood is family members being present and participating in the plan of care. The number one way to prevent delirium is to help keep these patients oriented to the things and the people who they are most familiar with. So one-on-one sitters who are familiar to these patients, and we do acknowledge that not all family members or caregivers are available 24 hours a day. But in these instances, being able to redirect a loved one and provide a familiar face, essentially, is really the number one prevention strategy in the absence of that identified individual that is familiar with the patient, just having a one-to-one sitter. Now, that's difficult because that's not a level of care that's provided in most nursing homes. But when we're looking at intervention, we want to tend towards our behavioral strategies as our number one item in our toolkit. The other strategy is education. So it should be said that any patient who is diagnosed with mild cognitive impairment or on any end of the spectrum of a neurocognitive disorder, family members need to be educated up front. They need to be warned that delirium can develop when there are changes in the environment, changes in one's medical conditions, changes in the absence of these assistive devices that we've talked about earlier. And so education is absolutely crucial to prevention, and having run an outpatient geriatric clinic myself at the VA for 3.5 years, one of the places where I was able to impact the most was educating caregivers in the preoperative assessment. So when I had geriatric patients facing surgery for any reason, not only did I medically clear them for surgery, but part of that pre-op assessment was delivering the risk to the surgeons about the possibility of postoperative delirium, but also educating the family on what to expect. And like we said before, if you're on the order of 50%, there's a really good likelihood that that education is going to pay off big time.
The one thing, if you don't mind me adding, is that
Please.
prevention is really our best treatment for delirium. Once people are delirious, in some ways the cat's out of the bag, and now we're kind of trying to play catch up with whatever we missed to begin with that causes kind of acute confusional state, encephalopathy, what have you. Some things are unavoidable, but lots of the examples Dr. McCaleb gave today, you can imagine how if we had kind of been proactive and maybe kind of made sure that was happening every day or multiple times a day, that we could have avoided some of those confusional states. Thank you.
So that was prevention, the evaluation. So as we said, a history and a physical exam, a lot of times the history may not be available from the patient, but certainly making a physical assessment, which can include everything from how you found the patient and making sure that you describe the scene, I would say, is really important. And sort of paint the picture of how this delirium may have potentiated to full-blown aggression or agitation. The primary way of that will manifest is through physical restraints. So restraints are not a treatment for delirium. They're not really a treatment for much, but in general, when patients do end up getting restrained in the hospital because they're either trying to get out of bed or there's some, something going on, that absolutely that's like adding fuel to the fire of a delirium. Basic lab workup I put there for you, and an EKG. Certainly, urine drug screening might be advisable in an emergency room setting. More for my purposes, I'm just going to look at the MAR, the medication assessment reconciliation. I'm going to look at what medications this individual has had on a PRN. How many doses have they had? Are there narcotics on that list? Are there benzodiazepines on that list? So I don't need a urine drug screen to, find out what this individual has been receiving. Chest X-ray is definitely reasonable. I would also argue just pulse oximeter and knowing whether or not the individual is hypoxic so you can intervene more urgently. And then, as I said earlier, I gave you the example of CT and MRI. The MRI, if you are suspicious for an acute stroke, number one. Number two, you know that the individual can tolerate being in the MRI machine. It doesn't do much good to recommend an MRI if somebody won't sit still, because you won't be able to actually obtain images that are diagnostic. But certainly you want to be curious and mindful of this being presentation for a new stroke if, for example, the individual presents with a facial droop or a limb with decreased strength. And then lastly, the management is similar to the prevention. The number one management strategy is prevention, and in the moment and when this has been identified, that's where you want to encourage family members to the bedside. You want to encourage gentle interactions with the patient. You definitely do not want to use any form of restraint. The last medication, if ever used, is a benzodiazepine. The only exception to that is terminal delirium. So terminal delirium, as we had said earlier, is when all reversible causes have been searched for. Can also be based on what the goals of care are with respect to that. However, based on that is the only exception to when benzodiazepines should ever be used in an elderly patient, in my estimation.
How about alcohol withdrawal?
And alcohol withdrawal, thank you for pointing that out. So alcohol withdrawal is absolutely an indication for benzodiazepine for stability. But in general, outside of that, benzodiazepines, Ativan, all potentiate delirium, make it worse. So all non-pharmacologic means are first line. In the long-term care setting, kind of after some of the acuity has sort of ratcheted down, I encourage family members to bring in photographs, to bring in blankets, pillows, things that are familiar to the individual, and to be put in their environment to help them feel oriented, to help them feel more secure, and make sure that, again, you're addressing the patient in a gentle approach, and in lower vocal tones, not yelling at these patients when they're not doing what they should be doing, quote unquote. And kind of my final thoughts on this are that, I feel like delirium is a really good lens for looking at our healthcare system at large, because it's not about having patients adapt to our care environment. It's about us adapting to the individual person and making sure that we're meeting their needs and that we're getting their background. Somebody asked earlier about getting information from the family. That's 100% crucial, because the more you can find out about somebody's background, the more you can find out about an elder geriatric patient's life, their career, what is important to them, what was important to them in the past. You can unearth interventions, you can find out things about that individual which will then help you moving forward as you treat them and as you create a safe environment for them in more of the long-term impaired cognitive state of dementia. So in any event, I'd definitely like to entertain any questions. What's the main difference between delirium and dementia? So delirium is the acute change in cognition, defined over a shorter period of time, whereas dementia is a long-standing shift in cognition. And one of the things that I also wanted to mention is that, in the beginning, a lot of times I read in notes where somebody gets admitted to the hospital and they're delirious, and on the list of diagnoses, it's their dementia is progressing. Well, that may very well be true, and you should validate families who believe that their loved one's dementia is progressing and is getting worse. But an episode of delirium does not necessarily mean that they won't return to their previous level of function.
That's a great question as well, because we will actually be discussing more about dementia during our next session, which will be Wednesday, September 19th at 12 p.m. So look forward to tuning into that one as well, please.
Just going back with what Dr. Sharma mentioned, alcohol is certainly a situation where benzodiazepines are indicated. Also, on individuals who have been on benzos for long term and then are being weaned off of them, benzodiazepine withdrawal syndrome, it is indistinguishable from an acute delirium. If you'd like to, oh, sorry, I thought that was another question.
Any other questions out there before we wrap up for the day? Feel free to send them in the chat, or take yourself off mute with the little microphone icon in the lower left corner of the screen.